Welcome to our live of the second IPNFA Online Congress. And I hope people are coming to our room this morning in Brazil and evening in Europe and late evening, afternoon in Europe and evening in Asia. So first, I want to welcome my colleagues, speakers, my friends, close friends. And so I should say good morning to Leandro, that it's here in Brazil. And good afternoon to Marcel, Suzanne, and Agnieszka from Germany, Sweden, and Poland. And good late evening to our dear colleague from South Korea, Shin. Good evening, Shin. So yes. We are very happy to be together today for this live. And a small history for you guys. This is our second online Congress. We as an international association, we have AGM, annual general meeting, annually since 1990. So we usually see each other every October in some country of the world. From 4 to 4 years, we see each other in Vallejo, our mother center. And due to the pandemic last year, we couldn't have our Rio AGM, and then we decided to create our first online Congress. And I should say that it was a very nice choice, because for our surprise last year, we had more than 5,000 participants from 54 different countries. And so we are very happy with the results. So this year, besides this 5,000 people, they are already invited for this online Congress. We have close to 2,000 more from different countries also. And so this is very successful for all of us. And I'm happy to be here with all of you. So the main purpose of this live is to answer some of the questions that were living on the box right after the lectures. So after all lectures, if you watch your lectures, you could see if you have any comments, questions, or suggestions, you should leave on the box below. So we select the questions. I hope we can answer most of them. And at the same time, if you have any question right now, you can write on the chat on the YouTube channel. And besides all of us here, I'm together with the speakers in this Zoom meeting, and we have a very nice background support from our colleague Karsten Schaefer. He's our vice president, and he's over there answering main questions and also putting some articles if the people need it and everything. So if you have any special question, put it in our chat, and Karsten is helping us to deal with this. Okay? Dear colleagues, you ready? So we're gonna start with our first lecture from Marcel Gzebelis, our colleague, our senior instructor from Germany. And he gave a very, very nice lecture about irradiation. There is a topic, a very interesting topic in our concept, and usually raises some questions about it, and people are really interested. So our first question to Marcel is, Marcel, be ready. May I ask, how would you apply irradiation for patients with ataxia? both limbs or trunk?
Okay, so hello from Germany. So thank you for watching this live chat. So answering this question, of course, you can use irradiation also on ataxic patients. So the first thing every therapist should consider is what is the goal. So presumably with ataxia, one of the major symptoms are these coordination aspect. So the inability to hold a movement, hold a limb, so the like a static contraction, or to make a smooth movement, especially in an eccentric way. So if you want to use irradiation, actually, so one principle which I did not point out too much in my presentation, since I was focusing on other aspects, is you should strong parts of the body in order to stimulate the weaker ones. So from strong to weak, if you want to use this kind of terms. So depending on your patient, you should think, okay, which is the better part, the better working part. So if the ataxia concerns mainly the trunk, of course, then it would make sense to start from or initiate irradiation from the limbs. And then it's the question is it upper limb or lower limb? And then you can incorporate this aspect of treatment on the ataxic patient. Yeah, vice versa, if the limbs are more affected, you could use the trunk. One major principle is the affected part should be in a closed kinematic chain. So if it's in an open chain, as I was explaining in the presentation, you are a little bit limited concerning the development of force. So just an example, if the trunk is the problem, of course, we can work here on the upper extremities in sitting position, but also you can pick up some positions from the mat activities. Quadruped would be very nice. So on hands and knees or something like that. Okay, so that was basically the thing. If it's the extremities, lower extremities, functional positions like sitting, high sitting or standing would be very suitable. And if it's upper extremities, yeah, then as I said just a moment before, closed kinematic chains would be favorable versus to open chain. Yeah, so irradiation is more like a reaction. If you want to have voluntary movements for the upper extremities, then of course you can do it, but then I would not do it by irradiation, like an open chain movement with a hand grabbing something. Then irradiation is maybe not the favorable way of stimulation. Okay, I hope that was answering this question enough for the moment.
Okay, thank you, Marcel. And so we're gonna pass to Leandro now for one question.
Yes.
And Leandro talked about geriatric patients in PNF. So there is this first question asking about how to give better tactile and proprioceptive stimulation to the elderly population.
Mm-hmm. Okay, so good morning, Brazil, afternoon and evening for all of us that we are spread all around the globe. It's an honor to be here sharing this classroom with all the people and mainly with the instructors who developed the PNF concept around the globe. And talking about the question itself, when we talk about geriatric patients, nowadays we have to talk about frailty syndrome, right? There is a kind of a categorization for the geriatric patients. They're, uh, they are classified as robust, as frail or pre-frail patients. And the signs of the frail patients are 3 of the 5 listed by Fried in 2001. That means 3 of the following ones: non-intensive weight loss, fatigue, loss of strength or sarcopenia described by literature, and mainly gait speed and limitation in activities, daily life activities. What I would like to connect with this literature described by Fried is that we mainly can approach sarcopenia activities, daily life activities, and gait speed, right? So the goals would be those 3 for geriatric patients we can manage with PNF. And talking a little bit more about tactile and proprioception, tactile is one of our basic principles. We have lots of basic principles. We have lots of tools that we can approach the patient. And then tactile is one of the most important ones that we can put it together with other stimulus like resistance, manual resistance, approximation. We can use together with other exteroceptive like visual cues or verbal comments. So I would say if I would like to improve the tactile stimulation, I wouldn't do just by itself. I would analyze the activities, or if it's daily life, or if it's gait speed, as we have talked. And not only with tactile, but joining other basic principles and procedures to approach those geriatric patients in direction to the activities we need. So not only tactile, but tactile is something that we can take together with us to approach those frail patients in the hospital or in the clinic or at home. Stimulus that they are portable, right? They are not equipments. They're every day together with us in everywhere in different environments. And by itself, together with other principles, we can improve the proprioception of the patients. So I think they are all together, right? We cannot just think about tactile as one tool that should be improved or approached with patient, but I think they should all together, depending on what we need with the patient, be used to improve the proprioception and the activities. Okay, maybe that's the best. It's an open question, but maybe by now it's the best answer for this. Then if we need to get back, no problem.
Thanks, Leandro.
You're welcome.
So now we move to dear Agnieszka. So Agnieszka, your first question is if you think PNF is a good concept for working with infants.
Hello, everybody. Greetings from Poland. And I'm also proud that I can be speaker during this Congress. And thank you for this question. It's not easy, but my answer is yes, I think we can use PNF concepts also in infants. And of course, it depends on condition of the child and on the age of the child. But as Leonardo told just 1 minute ago, we have different tools in our concept. So we can use visual inputs, and we can use visual stimulation to provoke movement of the child. And we can also use verbal stimulation for older infants. So I think I'm thinking about infants 6 months, 7 months, and it's better, they're better cooperate with us during treatment. And in my practice, usually I use traction, for instance, especially for floppy children. If we can facilitate their trunk, to put the trunk in the correct position. So we can use traction on the trunk and on the head. And also we can try to use even resistance. And if you imagine a small baby and we can lying on lying on one side, and then we use one visual input. For instance, I don't know, one bear. This is not bear, I know. But then if this child is looking down, we can resist the head, the neck. And this is part of neck patterns in PNF. So we can use this resistance in different situations. Also in infants at the age of 10 months or 12 months, when children are trying to stand up. So we can use also approximation and resistance in standing position. So I think that PNF gives a lot of possibility, but we have to think how to prove this is effective. So this is our task for the future. Thank you.
Thank you, Agnieszka. So now I move to my dear colleague from South Korea, Shin. Hello, Shin.
Hello. Yeah, I'm so glad to have a lecture in 2021 IPNF Online Congress.
Okay. So Shin, the first question that I have here for you, it says, do you have any evidence to support your chin tuck exercise with tongue pressure sticks?
Yes. How do I answer this? Simply, my answer is no, I don't have any research evidence to support my treatment. But I'm thinking about why this audience raised this question. I guess the questioner seems to think that my treatment is really new, but my treatment is not a new one. I just used the 2 wooden sticks, which are something like a screwdriver, as a tool, because when I treat the neck patient, I sometimes use this kind of sticks. For example, a patient is wearing the Thomas color or Philadelphia color, is neck color. It is hard to put my finger between chin and collar. So I just use the stick to make it easier to facilitate the deep cervical flexor and more easily apply the PNF pattern and technique properly. That's all. Enough answer?
Okay, Shin. I think it did answer, and if they still have questions about it, they can write on the chat on the YouTube, and Karsten can send to me. Okay? So, okay. So now, next question is for our dear senior instructor, Suzanne. And Suzanne talked about Bell's palsy, facial paralysis. And one of the questions that I have for you, Suzanne, is if it's possible to have any improvement using PNF in a chronic patient that didn't have fully recovery after the Bell's palsy?
Thank you, Monica, for the question, and welcome to Sweden in the afternoon. Here we have autumn right now, or starting with autumn. I have followed 5 patients during 10 years. And they came to me 1 to 6 years after onset. They came from the university hospital, and they wanted to see, the doctors wanted to see how PNF would work with this condition. And what we saw, I treated the patients regularly. First, the individual program, of course, and then I integrated more and more self-training. And we have a status from the beginning, 2 independent physical therapists, myself, and a physical therapist who does not treat patients with PNF and have no knowledge more than basic knowledge. Measurements were undertaken, and we saw improvement, which we then could measure during the first 6 months, the first 1.5 years, and then follow up after 9 and 10 years. And what we saw, and I think that that is something that could also be seen by patients. I consider those patients as chronic patients, as they were 1 to 6 years after onset. And what we could see was an improvement in nearly all of the mimic muscles. And what was very interesting to see was during the summertime, they didn't train that much. They didn't come to the clinic for about 2 months, and they should only train in the self-training program. They set out of the program about for 4 to 6 weeks, and all 5 decreased the activity that was measured. And we could then see after about 6 to 8 weeks, again, of the same training, they gained activity again. So yes, I would answer yes to that question. Of course, then we haven't talked about synkinesis, contractures, and other problems. But in those patients, I saw it is always a hope to try to train, as we saw that the activity decreased during the summertime and then increased again during the new activity time, and training time. So I would answer try to that question.
That sounds very nice, Suzanne. So in this situation, this is my personal question now. So in these cases, perhaps the people should be training like frequently, right?
Yes, so they trained 2 to 3 times a day at the beginning. They came in the clinic at first, the first 8 weeks, 2 times a week. And then they came every 3rd week and every 4th week, every 8th week. And every time they came into the clinic, they got manual treatment. And I think it's very important also, if it's possible, to have integrate the manual treatment, because you feel it in your fingertips. And then you can also do the corrections of the self-training at the same time. So starting out in supine, progressing to sitting, and then self-training program, and check that out, which I did every time. And then I usually do that always on the isolated motion. In the beginning, we want to have a lot of activity and motion as possible. But as the synkinesis could be a problem, we do not want to have too intense activity all the time. So we have to always have this isolated motion as a thought in our treatment. So you always have to integrate that. In the beginning, it can be difficult to do the isolated motions. You need to have the activity, but then always aim towards isolated motions. I hope that could be an answer on your question.
Okay, thank you very much, Suzanne. So now we come back to Marcel. So we kind of try to get one question for each speaker, so you don't get bored watching all the topics. And then Marcel, you ready again?
Sure.
So your second question, it concerns if it's training with irradiation, let's say a drop foot, could affect the damaged nerve. And how often should it be done? And if it should be done until fatigue?
Okay, so that's a question for number, how many pills I have to take to make it better. And unfortunately, this answer is not so clear to say like when you have a medication where you have testing serials. So basically, we should think, okay, from the approach, we can work with PNF directly or indirectly. And of course, if you take the case here of a drop foot, as a direct treatment, we have some techniques. We have a procedure like timing for emphasis, where we can get a direct impact on the weak muscle groups. But we can also go for indirect treatment. And so as Susan was saying, like this the Bell's palsy is a peripheral nerve problem. You should practice as much as possible. Yeah, and so also like if you cannot have a treatment by a therapist, then the home exercise are getting very important. In general, it makes sense to integrate some part into a functional or activity style that the drop foot is not working only pulling up the foot and up and down, but integrate it into some situations like you can, if there is a little function, like you can have it in a balance reaction. So in my presentation, I was explaining how the dorsal muscle chain will get active. So the triceps in this case, when you have a push from behind, or if you shift your body weight forward, the same you could do the opposite way. And then if you're going more like putting the weight more on the heels, then finally the foot will get a stimulation as a balance reaction to come up. So thinking about fatigue, I mean, there are different points of fatigue. We can have a local fatigue of the muscle, but we have also this kind of central fatigue. Yeah, so just from the synapses, you come to a moment where it doesn't make sense to continue practicing. Like same like when you start learning something complicated like juggling, and you try to throw up the balls, and then after maybe 1 minute, you're not improving suddenly. You make the same mistakes all the time, and then it's better to take a rest and try 15 minutes later the same. Then you have like a recovery from central. So of course it makes sense to work to the limit, to continue to stimulate in as I see that. Yeah. So irradiation can be very useful, also in the sense that the patient has some variations in the exercises. So that's not always the same type of pull your foot up, down, up, down. It's kind of boring. And if you can integrate it, then it's just a different way and an additional way to stimulate. Okay, I hope that answered it.
Okay, thank you, Marcel. So we move again to Leandro.
Monica, excuse me.
Yes.
I have one question for Marcel.
Ah, okay, go ahead.
Leandro, go ahead.
Marcel, please. Who were those two people in your presentation, the one in sunglasses and the Yogini one. Do they work with Pnf?
Yeah, they are some colleagues of mine, and one is like more a physical trainer, and the other one is a cool guy. He is always so smart, but yeah. Okay.
Thank you.
Welcome.
Okay, Leandro.
Let's go. Loud and clear.
Okay. So there is a question saying, you mentioned gait speed to predict life expectancy. Can you share more the difference between sex and special disease group like Parkinson's disease?
Sure. So we need to think it's a must, actually, that we work with an evidence-based concept. So as part of PNF concept, we have in our philosophy, and we say we are evidence-based, right? So indications, contraindications, it's in the literature. And we should have the literature by our side so we can produce evidence-based science and practice. So we need to get back to an article. I have it open here with me, but we will have it soon on the chat. And it's an article that comes from, it was published in 2011. It's a review article by Studansky. And this paper tells us that gait speed is a survival predict indicator in older adults. So they reviewed the literature with nine previous papers, and it brings us in total the results of 34,485 patients. And it tells us that gait speed is really a predictor for survival, right? It was published in the Journal of American Medical Association. It has slight differences from men and women. So answering the question about the differences about men and women, we have in the article, who wants to go through it after, two graphs that, for example, just bringing the results that they had. If we pick a person, a man with 70 years old that walks 1.6 meters per second, this person, according to the article results, may live 25 more years, right? So until he's 95 years old. But for example, a woman who at the 70 years old, who walks 1.6 may live 30, not 25 as men, but 30 years old until her 100 years old. So there's a huge difference, like 5 years in between men and women, right? And the most interesting, one of the most interesting things of this article is that these results may be improved in life if the person walks faster. This person may live more, and it doesn't matter the pathology. It's a good and interesting article, because as we talk in PNF, we work much more with activities than health conditions, right? So it doesn't matter if this person has a hip replacement or has lung pathology or cardiovascular pathology or a Parkinson's disease or any other of those orthopedic, neurologic, or rheumatologic or clinical diseases, all of those may produce low gait speed. So it doesn't matter on the pathology. I don't really know exactly about Parkinson's disease, if we have any publication concerning gait speed, Parkinson's disease, and survival. But the thing is that this article with this lots of people that they reviewed in a range of 16 years, 26 years, it's interesting for us to know that gait speed may decrease with any pathology. So if it decreases, it may decrease also life expectancy, okay?
Thank you, Leandro.
My pleasure.
So we move again to Agnieszka, my dear. So Agnieszka, there are many comments about your interesting lecture with children.
Thank you for these comments.
And it's a topic. There was really a big demand. This is another thing that I didn't say at first, at the beginning, when by the introduction. One of the reasons for us to choose those topics came from the demand from the people from the first IPNFA Online Congress. And your topic was one of the main ones that people really asked, how to use PNF with children. Is this possible? And then your next question is if it's possible to use with spastic children, because in your lecture, there are no example with spastic children, CP kids, or so that's a question.
Yes, you are right. And indeed, I didn't talk about children with spasticity, but I treat this kind of children in my daily practice. And there are children after operation of brain tumor or with cerebral palsy. And sometimes I have also children after operation of spinal cord injury or tumor of spinal cord, and they have spasticity. And every time we have to choose proper tools for every child, depends on functional state of these children. So we use different strategy for children with hemiplegia and bilateral hemiplegia, and also for paraplegia. So for instance, for children with paraplegia after spinal cord injury with spasticity, we can use more irradiation using neck patterns and scapular patterns and upper extremity patterns. And this is a different strategy than in cerebral palsy children, because in this case, we have to think about possibilities of these children. So we have to think about if they are able to see and to hear, and if they understand what we are doing during this treatment. And maybe people wants to have any recept for these children. And I think that we have a few procedures in our PNF practice which are useful for different children with spasticity. And I think the first one is trunk stimulation, because this is a base for our activities. And we have different phases of motor control in PNF. So we have mobility, we have stability. So for instance, this is stability of the trunk. And then we have mobility on the top of stability. And this is, there are neck movements or arm movements or leg movements. So we have to stabilize the trunk and exercise trunk. And the next important point, I think this is breathing stimulation, because if we have spasticity, then we use this tool to decrease the muscle tone. And maybe Next idea is to use rotation of the trunk, rotation of the neck, because if we look at children with spasticity, usually they use one or two planes for moving. So they prefer movements in sagittal plane or frontal plane, but they don't want to use the rotational movement. So this is more difficult movements for the children. So we have to exercise this. So don't afraid to use PNF, and this is very useful. And I promise that maybe in the future I will prepare this video. But pediatric is so huge field in medicine, so it's too difficult to tell about everything.
Thank you, Agnieszka. I think that was clear. And now we move to Shin again. Dear Shin from South Korea. And Shin, you have a question now. That is, what should I do with evidence-based practice if I can't find any evidence? For example, systematic reviews or clinical practice guidelines for patient treatment in a clinic.
Yes, I think it is a reasonable question. Yeah. So there are many options to solve this kind of problem. Yeah. Do you remember the pyramid of scientific evidence? Yes. So we can use the low level of evidence when you have no systematic review or meta-analysis. So we can use the low level of the evidence like a randomized control trial or core study, a case study, and a case report, and so on. And second option is to I recommend you change the searching keyword, because the searching keyword is very important to find the exact paper. For example, if we wanted to find the frozen shoulder and PNF treatment, but you cannot find any systematic reviews because I already checked it. But if you put in the searching keyword like PNF and adhesive capsulitis, or PNF and range of motion of shoulder joint, you can get 3 or 5 systematic reviews. So I strongly recommend you change the searching keyword. And one of the other option is combine PNF with general clinical practice guideline. For instance, when you're applying the PNF for the patient with sprained wrist, but we cannot find any systematic review, but we can use the management guideline of soft tissue injury or other post-operative treatment. So if you have your patient on the acute stage of soft tissue injury, you can start with the very gentle rhythmic stabilization or stabilizer reversal, or you can apply the irradiation on the wrist, elbow, and shoulder joint. So you can use the PNF as your treatment method in the management guideline. It's very useful to clinics. And the last option is a little bit difficult. The expert says that single subject study or case study can give the answer their research question. So I know it's a little bit difficult to make a baseline to the subject design, maybe give the future for the next study. That's all.
Thank you, Shin. Very nice answer. So now I'll come back to Suzanne. Dear Suzanne again. So there is a question here, Suzanne, saying that we know there is home program exercise is very important. Nowadays, we know how important it is what the patient does after or between sessions of treatment. And home program sometimes is really hard for the people to follow. And then a person questioned if you think the use of the app helped with the people to do the home program.
I haven't done any study. Thank you for your question. It's very interesting. I haven't done any study for that. That would be a good question and a good study to do, actually, because the feedback I get also from people who do not consult me, but they just give feedback. They mail me and they say, thank you for the app, that has really helped me. Yes, I think in this digital time that we are living, I think that then it is somewhere the app that I have developed that gives you a reminder. So my suggestion is, as I also said and I talked about in the lecture, to try at least in the morning and in the evening. It's easy when you brush your teeth in the morning and in the evening, if you do that, to also do your exercises. And we do all know that it's difficult to do exercises that we have to do. But with a reminder, you get a signal that you should do the exercises that you self have chosen. You can choose some exercises for the morning and some in the evening, for instance. And the reminder, my impression is that then somebody, it's like an extra PT, as a not physical therapist, but a personal trainer, extra personal trainer that says to you, now you should try to do your upper part of your face or train the lower part of your face, whatever you have chosen. So a long answer on an actually short yes, I think that can improve the self-training. That is my impression and the feedback I have got. For many years, I didn't have the app. And then I did the follow-up, like I told you before, as an answer to your first question. I follow up the patients in case studies for 10 years. And really what we saw then, I come back to that, over the holiday times, they don't bother to train actually, even if there is motivation. There are other things that are more important. And I also agree that you should try to live in between and do things that are pleasure and gives you also a nice time. But now in the digital time, and I've been using the app now for since 2013, so it's nearly 10 years. And so I see that, yes, with a reminder and with a digital device, it is easier to train in the self-training. In the feedback I have got, but I haven't got feedback from all patients around the world who are using the app. So.
Okay, thank you very much, Suzanne. Now we kind of jump to each people and we're not gonna follow this direction as we did before because we have general questions, but here there are another question for Marcel. And Marcel, the question is, I would like to consult with Marcel about if it's possible to integrate irradiation technique into facial lines since facial lines are also similar to kinematic chains in some ways. Marcel, we cannot hear you.
Me neither. Is it okay now? Okay, so I'm not an expert for fascias, but I know that these facial lines or trains, they are corresponding a lot with our patterns, for example. I remember when I was starting to teach PNF, one participant, he was like an osteopath, and he said, oh, I like PNF so much. And I said, yeah, why? And then he said, yeah, because it reminds me of this facial mobilization a lot. And actually, there is a good connection. I mean, we work neuromuscular, so we have the structure of muscles in our name. And if you work with muscles, of course, you're working with fascias. Irradiation is more the neurologic part, so the innervation part. And here, I don't see the connection to the fascias yet, but of course, there could be some connections to find out. When we are moving, if you think about global movements, like we have in daily life activity, and force development, which is one topic of irradiation when we need to stabilize or when we need to generate forces. Of course, fascias help us a lot to save energy. Yeah, so when we are getting an elongation of a muscle, we elongate fascias, and then this elastic force, the passive elastic force, is helping us to save energy. Yeah, so probably many know the calculation that Australia would be empty if all kangaroos would develop their force just by the food they eat and get the energy from the food. But actually, when they jump around, they use a lot of these plyometrics. And certainly there are some connections for that, yeah. But in the sense of irradiation, when we think we want to stimulate a certain muscle group, I don't see the fascias as an active part, but as a supportive part. Yeah, but could be interesting, yeah, if we can link it to somehow. So when we do PNF, I mean, we are doing a lot of things at the same time, and we have impact on many levels, which means it could be different structures than we think we are treating. Yeah, so when we think we are working with muscles, of course, we are working with joints, we are working with other connective tissues, we are stimulating the mental aspect, the psychology of the patient. So there are so many levels which are outside of our focus, but happening at the same time. Anytime you do something in physiotherapy, you are treating at so many levels, but maybe you're not thinking about it. Okay, so I hope, yeah, maybe it would be interesting to get into these anatomic trains as Myers is describing them, so these fascias and how they connect to certain daily life activities. Okay, shall I switch on the sound now?
Yes, yes. Thank you, Marcel, for your answer. So, in between the general questions, perhaps I would send this general one to Leandro. So there is this question about how to use PNF in intensive care unit patients with no contractions, active contractions, and like patients with lateral sclerosis also. And so that's the main question. If we have something to do, if the patient doesn't have active contractions.
Nice. So we should consider that here in Brazil, at least, we have some good people working with PNF intensive care units. We should consider that we have many kinds of patients in the intensive care, right? So we may have acute, we may have chronic patients that they have an acute phase of their pathologies. And considering mostly the patients that they're in coma or they need sedation, they're sedated because of any infectious pathology. We need to think that their brains, their nervous systems, even the muscles don't work, they're still working, right? So it's not common. It's common that lots of people, they say after a coma, they remember about people talking. They remember about they were in the hospital, or they remember about being somewhere else than not in the hospital. And we may consider that we have stimulus like tactile stimulus. We have stimulus like voice, not visual, but verbal comments that they may help, right? And when we think about passive motion, we may think about that patterns, most of the times they move lots of joints at the same time, that they may help those patients. But not only that, we may think in activities that will come later when they recover from the coma or the sedation, that it's rolling, right? I usually say that when you touch in a patient in the bed, it doesn't matter if the patient is sedated, coma, or active, we need to think on rolling, because this person has the motor or engineer in the head, because this person has rolled a lot of times in the life, and we need to connect patterns. We need to connect from the extremities, from the head, scapula, pelvis, with the rolling, thinking about the kinematics and thinking about all the principles of rolling, right? If we think about a person that is starting to wake up from sedation, it's easier to work, for example, in sideline, that is a position where the person has already balanced reactions, and we have lots of activities like mass flexion for rolling. We can use, again, head to help, again, with the physiology of the philosophy of PNF, working with strong parts to set the patient to win, to use irradiation for the trunk. It doesn't matter many times if we have the cognition at our side, but thinking that we have lots of other tools and building up strategies without the use of cognition. Agnieszka, she mentioned when we work with children that they don't have lots of cognition, or when we work with elderly, for example, with multiple sclerosis, or sorry, I missed the word in English, Alzheimer, right? At the end stages, sorry, yeah, Marcel, I'm a juvenile Alzheimer. And we may work and we may build up strategies for working with those patients without the cognitive aspect. So we may think this since the intensive care unit until chronic patients. This is something that it's not easy to approach, right? We have to go out of the box, the regular box, and we have to build up special strategies for that.
Thank you, Leandro. So there is another general question here, and perhaps Shin can help. Shin, my dear. Shin, there is a question here, how to use ICF in a daily PNF treatment. And then it says, how to measure our results using this tool. After a PNF treatment, how we can measure our results using ICF.
I think we have to classify the level of the ICF, body structure function level, and activity level, and participation level. We usually assess the activity, perform the task, and then how much he assists. For example, minimal assist and maximal assist. And also we can measure the time achieved, or we can measure the meaningful distance. For example, my patient can stand up from the 50 centimeters of the chair, but my patient cannot stand up the 30 centimeters yet. But the activity level is to test the performing. But the body structure function level, we already have a lot of tool in the physical therapies. So we treat with the PNF, we just measure the tone assessment or muscle strength or range of motion and so on. And finally, in the participation level, we usually use the survey and satisfying the quality of life and satisfying their job and so on. So my opinion is that we have to divide it into the body structure functional level and activity level and the participation level. Yeah.
Thank you, Shin.
You're welcome.
Thank you. And there is another general question here, Agnieszka. Perhaps not just concerning children, but also children. There is a question about how PNF can help. We're coming back to spasticity, how PNF can help decreasing the muscle tone, for example, in a stroke patient.
Okay, so I mentioned before that we need proper muscle control in our body. And in my opinion, and I think another people, if we take total muscle tone as 100%, then in spasticity, we have parts in our body with increased muscle tone and another one with decreased muscle tone. So we have to think about normalization of this muscle tone. And I have experience with children, but I have also a little experience with stroke patients. And usually we can, of course, we can adapt our treatment to the goal of the patient. And usually in ambulatory patients, after stroke, the main wish is I want to walk better. So the main wish is walking at the beginning. And then if we analyze different structures and functions in the body, we can find different impairments. For instance, we can find weakness in the trunk, for instance, abdominal muscles. And then we can observe sometimes increasing spasticity in situation when abdominal muscles should be active. So when we exercise trunk with abdominal muscles, we can expect that after this treatment, the activity with walking or another activity with upper limb will be better, because spasticity will be smaller. So we decrease spasticity. And I think that we can also find another structure or functional impairments like trunk asymmetry. And if we measure position of scapulas and pelvis, and we see asymmetry in the trunk, then sometimes we have situation that one side of the body is elongated and the second one is shorter. So we can prepare a treatment to correct the trunk symmetry. And we can take good patterns to do this with good techniques, with in position easy for patients. And then my observation is when we correct this asymmetry in the trunk, then usually we have decreased spasticity and we have better activity in this patient. So I think the base for every treatment is really a very careful, detailed assessment of this patient at the level of function, structure, and activity. Thank you.
Thank you, Agnieszka. I think that was clear.
May I add something? Yes. Evidence-based practice says that one of the most effective treatment is the drug, but it's not used in physiotherapy. But evidence-based practice says that weight bearing decreases the spasticity, and then long-term elongation of the muscle also decreases the reflex of the muscle spindle, and then strengthening also decrease the muscle tone. But when you do the strengthening training, I more recommend to use the closed kinetic chain strengthening, not the open kinetic chain. Sometimes open kinetic chain will increase the spasticity, and then we elongate the spastic muscle. We start with the strengthening the antagonist muscle. For example, we have the spastic elbow flexor. I usually start with the irradiation in the elbow extensor, and then I give some stress reflex or timing emphasis on the elbow extensor, and more decreases the muscle tone on the elbow flexor. So elongation position also important. For example, how to say, symmetrical reciprocal scapular pelvic pattern also decrease the spasticity. For example, scapular anterior elevation with the pelvic post-flexion position also elongated the trunk muscle and also affect the decreases the spasticity.
Marcel first, seniors first, please.
So additionally to what Shin said about the different types of applications, when we think about the spastic muscle itself, usually it's not as strong as we think very often, because when we feel the muscle, you think, wow, this is so strong. But a voluntary contraction, you find very easily that the patient has no power at all in these muscles. And so besides this passive elongation or working with the antagonist, you can also go for direct stimulation. And especially when you go slowly with eccentric work into elongation, then you get an effect that the tone is decreasing while the patient learns to control these muscles at the same time. So this is a very useful way, besides the others, to control spasticity and strengthen the weak muscles.
Excuse me?
Leandro? No?
About the same topic, some evidence shows us that we have the contralateral effect. And if we think about the antagonist, if we work contralaterally in talking about irradiation, if we improve strength in the contralateral antagonist muscles, we should improve agonistic muscles. So this comes from the classical kinesiology, but we may apply this to the antagonist of the spastic muscles, right? This mainly thinking about hemi patients. And this comes to our philosophy when we talk about starting first from the strong parts, then going to the weak parts. I think this is very interesting because many times, many people forget about working with the strong parts of a hemi patient. And with these evidences, we may think that working with the strong parts, it's not for learning, but also for physiological strengthening the muscles that are weak on the hemi side, right? That was it.
Thank you, Leandro, for adding this comment, and Marcel also. And Suzanne, there is a question for you, asking if you work also with cerebral palsy from central nervous system problems, like hemi patients, and if there is too different than the palsy.
You mean if patients who have a facial paralysis at the same time?
Yes.
No, I mainly work with Bell's palsy, but also some patients come to me after, for instance, operation of acousticus nephrinome. But it's mainly the idiopathic paralysis that I'm working with and have specialized in. And those kind of patients are also seeking the contact with me.
Okay, thank you very much. And I think we finished our questions. So let's say if one of the speakers wants to ask a question or wants to make a comment, a general one, I don't know. So I wait for you guys. If you don't have anything to add, we can, let's see, someone want to add something, talk about something else. We are in a round table here, so you're free to say something. Okay.
I have one thing.
Okay, Suzanne.
There is a general question. What is new in PNF concept about the use of stretch reflex? And I just wanted to point out that finally there are studies who shows that we do not have proprioceptors and the stretch we cannot use that in the face, in the facial muscles, because we don't have proprioceptors as in the skeletal muscle. But so there are recent studies from 2020 And Carsten perhaps could put out that reference from Kubo that talks about the interaction from the trigeminal nerve, from the 5th cranial nerve with the 7th cranial nerve, so that the impulses can be carried and communicated. So I would say we haven't discussed that actually right now in the PNF Association. How do we continue with this? But as I said in my lecture, my, how should you say, my opinion is, or I think that we can use the stretch as an onset and to give the patient a feel of the contraction, because the patients say by hands-on treatment, they say, do you know, I felt your fingers quite a time after the treatment. What did you actually do? And this was that when you were pulling in my face. So that could be a feedback of the stretch reflex that something is happening. But at least you get, I would consider it a kickoff for an activity. And that is how we can use it and also stand behind the new research that are done and published about the proprioceptors in the face.
Thank you very much, Suzanne. And so my background here, Karsten didn't send any other question also.
Yes,
so,
Stephanie, Monica, excuse me.
Yes, Leandro.
Oh, it's just a point for all the ones that are attending that we would like from all of you suggestions for our next year Congress. So Benedict Boomer, one of our instructors, pointed on the chat on the YouTube that one suggestion would be the use of PNF in intensive care unit. So as this one, please, all of you, put in the chat your suggestions that it makes really easier for us to address the necessities of all of you guys who want to know more about PNF.
And Leandro, by the way, completing your comment, after we finish the Congress, people receive a feedback survey. And then one of the questions is this: topics for next online Congresses. So I hope everybody would answer this feedback. It's very important for us for improving the next online Congresses that we're gonna have. And so I want to say that you can browse our IPNFA website. There you can find the national contacts, the people that would help you in your own country, where you can have courses or lectures, symposiums, congresses about PNF, helping with literature and everything. And also if you need a deeper help in research, you can send a message to our research committee on our IPNFA Association, and they usually help a lot with this. And another point is that as the lectures are all recorded, they are saved on our platform. As this year, you can also watch the 4 lectures from last year's online Congress. And perhaps we can also put some subtitles on them. Last year everything was in a hurry because it took a long time for us to realize that we really couldn't see each other. And then that was close to July. And we didn't have 2-3 months is not enough to deal with all this technology and preparing the lectures and everything. So we didn't have a chance to prepare subtitles last year. And that was one of the requirements from the people that attend the online Congress from 2020. This year we had subtitles in Korean, in Japanese, and in Portuguese. Those are the 3 languages that asked more for subtitles. So perhaps talking about myself, I personally intend to do the subtitles from last year's lectures, perhaps some people in Korea and Japan also, and maybe in another language if it's necessary, to help people that it's not so good in English to understand all the details. And another point is, if you have a friend that it's kind of, oh my God, I didn't enroll for this Congress, maybe that was a good one, you can still enroll from now on if you want to, because all the lectures are still in our platform. You can enroll, you can watch all the lectures, you can even make comments, and you can be answered. And I think the main purpose of this is to narrow the communication around the world and from people that are interested in our fascinating concept. So I want to say thank you to everyone that is here watching us now and attending our live. And I want to say thank you, a special thanks to all the speakers. Without you guys here, this wouldn't be possible. And I'm really proud of all of you because the lectures are so good. And I'm so glad that you accepted the invitation. And I hope we can count on you forever. And I must thank also all the members of the IPNFA who always helped us with preparing all the stuff and giving feedback and everything. And I must thank also my son, Lucas Silento, who is the technical guy that made this possible also. So I must thank him, because without him, this wouldn't be possible also. And I hope this is gonna be something that we're gonna keep doing year by year. And then we can gather more and more information about PNF, easily reached by every PT, OT around the world that are interested in our concept. So thank you, everyone. And I hope to see you soon.
Thank you, Monica.
Thank you, Monica, and thank you, Carsten.
Thank you, everybody.
Also, I'm so sorry, I forgot to thank my partner, my dear partner, Carsten. That is not, he cannot be seen here, but he is really my partner on this project. He helped me in every detail, and now he's on the background helping with the questions, adding the articles. I'm sorry to not mention you, but you are in my thoughts every minute because you're here on my WhatsApp. Thank you so much, Carsten. And I really hope to see you all pretty soon. Okay?
Obrigado.
Eu que agradeço.
Bye-bye.
Bye-bye. See you all. Tchau, Marcelo.
See you.
Ciao.
Tchau.
Tchau.